Okay. All right. Well, it's 8 a.m. so we'll get started. And delighted to have Heidi Tweed to be talking about note bloat today, and Betsy will introduce her in just 1 second. I do want to give a shout out. This Grand Rounds is kind of a paired Grand Rounds to a follow-up one on October 15th, where we're having an external visiting professor, Dr. Scott Maneker from Penn, who is going to be talking about navigating the new office visit documentation guidelines. So between the two Grand Rounds, the hope is that our workload in the ambulatory and frankly the inpatient setting will be improved and focused on patient care. So with that, I'm going to hand it over to Betsy Trowbridge.
Well, good morning, everyone. I am really honored to be able to introduce Dr. Heidi Tweed, who joined us very recently in 2020 and is a clinical professor in the Division of General Internal Medicine. So there's a lot of things to tell you about Heidi, and I'm going to just choose a few select ones. She went to medical school at the University of Minnesota, where she was elected AOA in her 3rd year, and did her residency at University of North Dakota, where she actually stayed and practiced for many years, achieving the rank of clinical professor. She was a general internist there. She worked with residents and medical students, and actually worked significantly with women Kurdish refugees, and was expert in that area. We were just talking. She said, interestingly, they in their culture had no word for menopause or depression. So when she was talking to them, that was an interesting thing she found out. You know, she's developed an area of expertise in informatics, and after University of North Dakota, she moved to Stanford Health in South Dakota and the Stanford Health Medical School in South Dakota, where she really quickly rose to the top ranks there. She started out as a ambulatory and informatics medical director in the ambulatory setting. She became the chief informatics officer for that region, and then finally became the chief informatics officer for Stanford Health in its entirety, which is no small feat. She then came to join us because she really wanted to be more of an academic enterprise. And she practices general internal medicine in the Division of General Internal Medicine as a float, but she was really hired here as a leader. And she came in with really 2 important positions. One, she was hired as the Associate Chief Medical Informatics Officer for UW Health. And she was also hired as the Academic Program Director for Clinical Health Informatics Professional Programs in ICTR. And she has taken on developing in her first few years here, actually 2 master's and fellowship programs, a fellowship program in informatics for the School of Medicine and Public Health, and a master's in informatics for the Department of Population Health. She's highly decorated. She's a fellow in the American Informatics Association. And I think probably to her, she has been elected by her informatics peers as a finalist for the Epic Academy Award, which is actually an award where her peers nominate her for contributions that she has made to informatics. And one of those areas is note bloat, and that is an area where we need a lot of help. And so, Heidi, I'm going to pass off to you.
Great, thanks for that, Betsy. So first, to start with, no one involved in the organization of this program has any financial disclosures. And today I want to talk about sparking joy in provider documentation and the battle on note bloat. So I think we'll learn a uniquely American problem, and we'll talk about some of the origins and then what we can do to help battle note bloat, both in our own notes and collectively. So I love this quote from Marie Kondo. I'm sure many of you have seen her Netflix series or read her books, but she talks about sparking joy, and she talks about it in the sense of home organization, but I really think in my role as a clinical informaticist, this is really relevant. So our goal is to help more people live a life that sparks joy, and we're committed to offering the simplest, most effective tools and services to help you get there. So today I want us to think about this. Our goal is to help more providers have a practice that sparks joy, and are committed to offering the simplest and most effective tools and services to help get there. I think we could substitute that word provider for clinician or nurse or any other role that uses our information systems and our electronic medical record as well. So we know that note bloat is at the national conversation level, but it's also relevant here at UW, where last fall, we did the Class Arch Collaborative Survey. And yes, we chose, this is a provider and clinician satisfaction with the EMR survey. And we did choose to do it in the middle of a pandemic because we wanted to know. We had done the class survey 2 years before, and we really wanted that follow-up data to see has anything changed since the first time we did this survey. And this is our answers to the question, if you could fix 3 things in our EHR tomorrow, what would you fix? So this is an open-ended a free text question. And you can see that our faculty physicians, which is the data that I looked specifically at, wanted improved health information exchange, improved chart finding, improved orders, and improved notes. Those were the top 4. And I think the intriguing thing about notes is that that's adaptive change. So I can make technical fixes to make chart review easier to navigate, or technical fixes to help with health information exchange. But when it comes to fixing note and note bloat, we're really all in this together, because every clinician writes their own note, chooses which tools to use and what to say. So it's very much an adaptive change. When you look at the comments that our faculty physicians gave, here's a few highlights. Everyone complains about doing notes when really it should be the last thing we worry about. I want help with note bloat. The important clinical information is buried in the note under other clinically useless information. And note writing, give us note writing best practices. This is what our physicians were asking for. I think it's interesting that it highlights here, not only writing the notes, but reading the notes is a big part of the problem. So note bloat isn't just about the author. In fact, I think bloated notes increase the cognitive burden for many people in the healthcare system. So the note author is writing the bloated note and navigating that, but then all of the downstream readers, including other providers, other parts of the care team, the coding and compliance department, who need to wade through that note to help with billing. And then now with open notes, we've really introduced the patient more into the equation of the downstream burden. So if we have a hard time navigating a bloated note, imagine the patient who doesn't read notes all day for a living, how much work it is for them to navigate those notes. So this is an actual clinical note that I saw. I was a resident in the late 90s. Before my organization had an electronic medical record. In fact, as a resident, I went to the demos of the companies who we were entertaining buying their EMR. So this was a note that I saw. The physician who wrote this was an internist. He was a master of the American College of Physicians, and in fact, at the time was the only master of the ACP in the state of North Dakota. So this was not a slouch of a note. This was a note that was common in the 70s. And even before the EMR, when I was seeing this as a resident, I realized that this was not what I got to do anymore. I was not being taught that this was a note that I could write. And if you look back a little farther, I'm not a medical historian, but I am intrigued by the history of medical documentation. So this is from our own Ebling Library and is a text from the 1800s. The 1800s is an interesting time because it's really when the shift from case reports, prior to that time, really all of the medical documentation was much more case reports primarily for education or for yourself to remember the interesting case that you saw. during the 1800s was the shift towards, and early 1900s was the shift towards, maybe we should record things at the level of the hospital or at the level of the ward, and then eventually in the early 1900s at the level of the patient. So in this text, this author says, in recording a case, it is for the most part only necessary to put down under each head the symptoms or signs that are present. If the system be quite healthy, it should be said that it is normal. So it's interesting to compare that with what we're doing now, as we were just first starting to think about what should be documented. So over the years since the 1970s, I think what has happened is a lot of regulatory confusion and a lot of regulatory rules. So if you think about what our notes are about now, coding and compliance has some say with certain bullets of the HPI and certain components that need to be there for different levels of service. Legal and defensive medicine has a role in how our notes have become bloated. Quality metrics, you might be told, in order to prove that you did something about the patient's obesity, you need to document that you counseled the patient in order for us to meet this certain quality metric. The payers might have different rules, especially the state Medicaids have a lot of rules surrounding what needs to be in a well child visit in order to be billed. And then the Joint Commission tells us we should talk about pain and what we're doing for pain, or various other safety measures. And now again, the patient is added to that mix as well. And I think all of us over the years have heard all of these various rules, all of which are open to interpretation. So we've heard from one coder, you need to do this, and you've heard from a different compliance department that you need to do that. And we just pull all of that into our note to prevent ever doing the wrong thing. We'd rather pull in everything but the kitchen sink than get a message saying, hey, you forgot to do this. You need to go back and do this. And I think that has really contributed to our notes growing. So here I think this was probably the biggest change and the biggest contributor to note bloat in recent years. And that is the coding regulations of 1995 and then the slight modifications that were made in 97 by CMS. So I'm sure this is familiar to all of the clinicians on the line, but this is the cheat sheet, frankly, for how coding is done on outpatient visits. And you can see that in order to bill certain levels of service, you needed to have certain bullet points of review of systems and history and have complexity, and you need to meet 2 of the 3 in order to bill that level. And it sort of goes on and on. The Annals of Internal Medicine and the American College of Physicians published a position paper about documentation in the 21st century back in 2015, and really said, they kind of admitted that we were sort of asking for this, right? So they sort of admitted that organized medicine was asking for a way to verify the cognitive services that were provided. But what ended up happening was that we were really only coding based on what was documented more so than on what was done. And it really became about adding all of these things to your note and more about coding and compliance things being added to your note than it was about concise and clear clinical documentation. And they also call out here that there was sort of a negative gotcha mentality that sort of sapped the joy out of the work and the professionalism out of the work. And I'm sure we have all heard the mantra, if you didn't document it, you didn't do it, which was very much sort of the feel of these documentation regulations. This is some work done by Adam Rule, who actually just joined iSchool at UW this year. He did this work as a postdoc at OHSU. And this really looked at the outpatient notes at OHSU in the decade of their use of the EMR. And you can see that the notes continued to get longer and longer over the years. And on the right here, it looks at the percent of the note that was pulled in from elsewhere or copied forward. So the percent of the content that was not novel within the work. And that continued to grow as well over the years. So it seems like note bloat is on this trajectory that is not going to stop unless we take efforts to stop it. And then this is an interesting study. This is 3 physicians who are very, informaticists who are very involved in the EPIC community. And they helped to implement EPIC in other countries as because EPIC is becoming more and more global now. And as they helped to support the implementation of EPIC in other countries, they noticed that physician satisfaction with the EMR was higher in those countries, and really tried to figure out why. And one thing that they noticed was that the notes in those countries are dramatically shorter and contain much less compliance content, much less bullets of this, that, and the other thing, and less sort of non-clinical documentation compared to the typical American note. And here is their data. So the light green is the length of the US note across organizations. And then the dark green is notes from countries other than the United States. And you can see that the average note length in countries other than the United States is 1,400, whereas in the United States, the character length is 4,000. And almost, they don't even really, they sort of just barely meet in the middle here, right? That the longest note in another country is still almost shorter than the shortest note here. So to give you some sense of what 4,000 characters is, this is using basic journalism translation. 4,000 characters is about 880 words, or 47 lines of text in your average Word document. So that is somewhere between 1.5 pages and 2 of a double-spaced Word document, depending on what font you're using. So we're writing, you know, a good paragraph of a novel, a good chapter of a novel a day, if you think about the number of patients we see in a day. But I think the good news is that in 2021, we're at a little bit of a new day for a couple of reasons. So there's some hope. In 2021, and we're going to hear more about this in a couple of weeks, but in 2021, CMS dramatically changed the documentation guidelines for outpatient billing. So everything I'm going to talk about with coding is specifically outpatient. There is hope that similar efforts will be brought to inpatient notes in the next few years, but that has not happened yet. So essentially, when you go back to our UW Health coding cheat sheet, everything with the blue X over it was removed from those outpatient guidelines. So all of the bullets of history and all of the bullets of review of system and physical exam are gone. And we're left with billing just based on our medical decision making. So how much mental gymnastics did you do to figure out what to do for the patient, or how much time did you spend with the patient? So this would seem that this would open the gate, and I think this was CMS's intention, to open the gate for us to do less of that regulatory documentation, partly in response, I think, to some of the data that I've already shown. So this was sort of highly publicized, I think. The professional societies highlighted this, our coding and compliance group sort of went on a road show to bring this to all of our departments, to educate to this. And yet, when January came around, the providers at UW Health really did not change their behavior at all. And I think that's just natural, right? Nobody woke up on January 2nd and said, I think I'm going to completely change the way I do my job today in response to this. So our notes continued to be the same length. The other thing that's different, I think, in 2021 is that there's been some legislation called information blocking. I think they named this backwards. This should be information sharing, but this is a federal government regulation that we must share any clinical information that we have, essentially with anyone who has legal right to it as soon as we have it. And to start with, it's a suite of about 20 items, 20 data points that we must share. It includes notes and labs and other types of results and problem lists and things like that. So that information is now flowing much more freely, both out of our EHR and into our EHR than it was before. So now we can start to think about our notes are not the total sum of the output of the visit. The provider note is one component of all of the things that happened in the encounter. And all of that data, including the things that happened in the encounter, but not in my note, flow both out through Health Information Exchange and to the patient portal. So other people can see that information even when it's not in my note. And elements from out in the patient chart that weren't necessarily in that encounter, like lab work done last week, is also flowing both out to Health Information Exchange and to the patient portal. So you don't need to pull all of that information into your note anymore in order for it to get to downstream readers, even outside of our system. So although I'm not sure we'll ever get back to this note of the 1970s, I think we're at a point where we can go back to the mid 1800s and say, what really needs to be in a note? What is helpful in a note? And not what we've necessarily been trained to do, because we were trained to the test, right? We were taught you need to have a 14-point review of systems because that's what billing said you needed to have, not necessarily because that was what we agreed upon was best practice. So back to Marie Kondo, I think it's time for us to think about tidying up our notes. So this is Marie Kondo's rules for tidying up your home. So you commit yourself to tidying up. You imagine your ideal note. You finish discarding things from your note first and show gratitude for them for having been there. Tidy by category in that location. Follow the right order, and then ask yourself if it sparks joy. So I'm going to walk us through some things that I think are contributing to note bloat and why I think those things don't need to be in our notes anymore. So first is the chief complaint. First of all, I've never liked this because is complaint really the right word? That starts with a negative connotation right out the door, right? Am I complaining or am I seeking help if I'm the patient? There is no coding requirement that you must have a statement entitled chief complaint. You do need to state somewhere in your note why the patient is there, but that often flows naturally in the history of the present illness. And here's some examples I've seen of chief complaints that I think are completely unhelpful and contributing to note bloat. So these are all, I should mention, every time I have a screenshot, it's a reproduction in a place system with the fake patient and fake data. In a dermatology clinic, seeing derm problem as the chief complaint for every visit is not helpful. That's why it's apparent that that's why they're there. And then I often see things like this, where the chief complaint is then repeated in the first sentence of the HPI, and then again in the text of the HPI. And really, how many times do you need to read the word headache to know that that's why the patient is there? And the biggest problem is the downstream readers need to scroll through all of this to find the more meaningful information in the visits. Another thing in the history section that I think complicates things is when the entire history of the disease state is repeated in the history of the present illness. It makes it very hard to find what's new this time. I see this frequently with copy forward of every past note going forward into the note and then just adding today's data. That makes it very difficult for the downstream readers, especially coders and payers and other clinicians, to find today's data. So really, this is what the overview section of the problem list was invented for, that you really keep track of that whole history of the problem out in the overview section and remove that from your notes. I think another location that's ready for us to rethink is the review of systems. So the base E&M codes in the clinic no longer require a review of systems section. And so the clinician, the provider, gets to decide if this is medically necessary. I think it's perfectly reasonable to consider incorporating the pertinent positives and negatives into your HPI, where it's more likely to be found by a reader than in the sort of long list of random review of systems. There's some interesting work looking at review of systems back in 2019. This was a review article, although there wasn't a whole lot of literature out there for them to review. But as they looked at these studies, their definition of review of systems was a a standard list of system-based questions that did not change based on what the chief complaint was. So much more like what we do as a review, not a focused review of systems, but a standard review of systems like during an annual exam. And they really found that very infrequently was anything found in that review of systems that yielded a change. And in fact, some of the questions they studied had a positive predictive value of 0. So I think it's time to think about if review of systems is something that needs to be in every note. So a la Marie Kondo, we will thank those things for having been in our note and move on. I think another thing that bloats our notes is pulling in lists of things. So pulling in problem lists and medication lists and social history lists, etc. All of this data is patient level data. So it lives out at the patient level. It's shared through health information exchange, and anyone who is in the EHR has access to it, and the patient has access to it in their portal. So pulling it into the note is becoming less and less important. But yet we haven't really changed our behaviors to accommodate the EHR. The encounter summary now contains all of this content, and it's frozen in time for the date of the encounter. It used to be that the encounter summary did not freeze the medication list. So if you wanted a medication list as of that day, you did need to pull it in, but that has changed as of a couple of years ago. And now that is frozen at the time of the encounter. And then again, all of this information is sent through information exchange. I think there is one legitimate exception to this rule in our current state, and that is in pre-op HMPs, because although we send the history data out to those other EMRs, they don't always have a workflow that incorporates it into their EHR as the patient arrives there to have their surgery. And we don't want to risk the patient being turned away from their surgery because they don't know the past medical history, because they haven't gone out to reconcile it yet. So I think pulling that into that specific use case for the patient who's leaving our system is still necessary. And then results. So I think we all see a lot of this in the notes that we review, pulling in a suite of labs, whether they're particularly relevant to that visit or not. There exists links of, last 30 days of labs, et cetera, to pull these things in. I think this is difficult to read, more difficult to read than out in its native state. These links often break, or you don't fully understand how the links work, and I think at times they can be dangerous. I've seen an example where pulling in a previous CBC pulled in today's CBC, but a diff from months ago, and the combination made it look like the patient had a condition that they did not have. It was caught in time before anything was reacted to, but I think it does highlight that unless you know all of the caveats of those links that they're using, it can be dangerous to pull those in or misleading. Also, I've seen situations where a patient was seen in the clinic and the physician didn't finish their note that day. In the meantime, the patient was seen in the ER, had more testing done that had quite dramatic results. And then by the time the physician was finishing up their note from the clinic visit, their writing of the note pulled in those labs from the emergency department, making it look like the testing that was done in the emergency department was actually known to the physician on the date of their clinic visit. And although we could prove in hindsight what all happened there, it makes it difficult for the downstream reader, the insurance company, the lawyer, the patient to understand how all of that information flowed into that note and what time all of that information was available. The good news is that for medical decision making and counting level of service in 2021, that commenting on labs gets you just as much sort of credit towards medical decision making as pulling the labs in. So saying the hemoglobin was low or her A1C is worse today counts just as much and is much more meaningful in the clinical context of the note than pulling in a bunch of labs. And then I also see a lot of miscellaneous data being pulled into notes. The top things here, the sort of name and date of birth and medical record number and name of the physician and all of those things live as metadata. So metadata is data that automatically is generated surrounding that element of the EHR. And so anytime that note leaves the system or is printed or is viewed in the EHR, this data is all available automatically surrounding that note, and you do not need to pull those things into your note. I think two subjective statements is a thing that we should be considering of the past. So the patient is a pleasant so-and-so-year-old woman. Those subjective statements, I think, are just note bloat. Is the patient always need to be pleasant when they're with us, and what constitutes pleasant? And then appears younger or older than their stated age, I think, is another note bloat component. There's actually an interesting study in the New England Journal of Medicine where they essentially showed that the physician or the clinician is actually the worst on the whole care team of being able to determine how old someone looks. And then patient instructions. That's another component that is frequently pulled into the note. And the patient instructions are part of the encounter summary and are shared through information exchange and to the patient outside of the note. I think another concept that's becoming more and more popular to help to combat the cognitive burden of the EHR is switching notes to APSO format. So essentially assessment and plan at the top. The University of Colorado they promoted APSO format in their notes a few years ago, and then just watched what happened. They made it easy to use those templates. They didn't mandate it, but they did have a huge percent of their physicians switch to that format and prefer it. And in fact, they found that the vast majority of physicians felt writing in APSO was easy, that they found changing from SOAP to APSO was easy or very easy, and that the time was unchanged to when they switched from APSO to SOAP. The total time spent in the note was unchanged. They found that reading APSO, that finding the relevant data was easier or much easier, that browsing through notes was faster or much faster, and that the majority preferred or strongly preferred APSO over SOAP. And I think this speaks to scrolling. When you're reading a note that is in APSO format and the assessment and plan is at the top, 95% of the time or so, that is what you want to see in that other note that you're reading, including your own past notes. Sometimes you might want to say, did they have a murmur or did they have a fever that day? And you need to look at other parts of the note. But the vast majority of the time you're saying, what was the patient for that day, and what did we do about it? And I think that just decreases a lot of scrolling time. The Open Notes group points to this study as evidence that patients may prefer APSO as well. So as notes were being released in the last year through Open Notes and through the information blocking legislation, they interviewed patients to say, what's important to you reading in a note? And really the common theme was that the notes should prominently and clearly indicate what the next steps in the treatment plan are. And I think we could all agree that that's housed in the assessment and plan. So housing that at the top of the note makes it easier for the patient to find as well. The other, I think, sort of technical fix that we have to offer for note bloat is collapsible sections. So within our own notes, we can insert sections that will collapse the portions of the notes that are less clinically important, especially maybe the attestation section where we're pulling in the information about this, the video visit, the mandatory video visit documentation, or other compliance data. That helps again to lead your eye to the assessment and plan and decrease the cognitive burden of surfing through the charts. I'm also a believer, and I want to put in a pitch here for not using the terms subjective and objective. I think that one of the medical schools I worked at in the past was a big proponent of not using subjective because they feel this makes everything the patient, it's calling into question everything the patient said. Well, that's all subjective. But of course, everything I did, the physical exam and the labs, those are all objective, and really puts that spin on the entire visit. So instead, terms like history of the present illness and physical exam. So back to our Marie Kondo. So if our goal is to help more providers have a practice that sparks joy, and we're committed to offering the simplest, most effective tools, one thing that we're doing at UW Health is launching a standard note. And the standard note sort of allows you to easily do all of those anti-note bloat efforts that we just discussed, and is really built specifically to meet the new 2021 coding and documentation regulations. It's work that we've done. A team of physician informaticists have worked with coding and compliance and clinical documentation improvement and legal and information systems to come up with this new note template. It's compatible with all documentation methods. It was launched in general internal medicine and family medicine back in July, and will be launched to all other specialties with our update in November. Our real goal was to decrease the cognitive burden. So we're looking at secondary factors like character counts and time and notes and things like that. But I think the cognitive burden is really our end goal that we wish we had a better way to measure. Sticking with one standard note will allow us to easily deliver the newest and most sophisticated Epic functionality out to everyone. For instance, the note is smart enough to know that you're in a telephone encounter or that you're in a video visit encounter, and will automatically pull in the video visit phrasing, or automatically knows that a scribe is involved in the visit and will pull in that scribe phrase. It's easier. It will also be easier for us to maintain as new coding and regulatory content comes along. We will again work with coding and compliance to update that template to make sure we're meeting those new regulatory requirements, and you all won't need to worry about meeting those. So here's a little bit of data from our pilot so far. So I'm highlighting Dr. Peter Kleinschmidt's data, as well as the Department of General Internal Medicine. So you can see our notes. We're cruising along in internal medicine and GIM at about 4,000 characters. So we're pretty average American note writers. Dr. Kleinschmidt started to think about Notebook back around here when we started discussing it, switched to a pilot version of our standard note here. And you can see that his notes have dropped from 4,000 to 5,000 characters down to about 2,000 characters. Our note went live in general internal medicine in early July, and that department has, with about 1/3 of their providers using the new note, have knocked about 500 characters off the average note. So if we think about that, it probably means that more than 1,000 characters have been removed from the notes of those that are using the new documentation template. And I don't think it's just about the technical fix of the template. That's just a tool for you to use to start to think about anti-note bloat. So I think that's what Peter has really done, is think about what's in my note that really doesn't need to be there, what's extraneous, what's elsewhere in the chart. And that's how we really get to shorter, more concise notes. Incidentally, Dr. Kleinschmidt has also knocked 2 minutes per note off of his documentation time as well. And that is consistent with data from my previous organization as well. Because I believe in full transparency, here's my character count. I am a float in internal medicine, so I do less probably chronic disease management than some of my colleagues. So I'm almost at the sort of European or non-US note length of 1,200 to 1,500 characters. If you are interested in the standard note and are not in one of the departments where it is already live, you can get to it through .standard clinic note APSO, or it will come to you looking like this with the update in November. And if you're interested in how to use the note, there is a ULearn where Dr. Kleinschmidt walks you through it. And that is the end of my slides, and I'm happy to take questions.
Okay, great. Thank you. Maybe we can stop sharing for a second. Let's see, am I up there? Yes. Okay, so a couple of questions in the Q&A. What is the thoughts about exploring note bloat for an inpatient setting as well?
Right, so we've been working on, Dr. Jennifer Passini has been working on standard note templates on the inpatient side as well, actually for several years. I think, unfortunately, on the inpatient side, we still have the components of physical and the components of review of systems and the component of history, because CMS has not changed those documentation guidelines yet. I think we all have hope that that's coming, but that was not first out of the chute. So I think very much we want to embrace the same philosophy on that side, but we don't quite have the same freedom on that side of the house yet.
Yeah. Then there's a couple of questions referring to most of what you've talked about seems to be very relevant for primary care and general internal medicine. How do you see this being rolled out in the subspecialties, particularly if you have a patient who's being referred to you for a second opinion? How will the referring physicians take to the abbreviated note? And has it been tested in other subspecialties?
So we have not yet moved this standard note into the subspecialties here at UW Health. At my previous organization, we did use a very similar standard note in the medical subspecialties, and we had about a third of the medical subspecialists were choosing to use that standard note. In the days of health information exchange, the other workup that you might have done also flows through health information exchange to that other organization, and your note is just a component of that. I also think as a primary care physician, and I've done not a formal study, but what I would call a straw poll or numerous straw polls of other primary care physicians who say, there's really not enough out, I might have 20 patients that are seeing a specialist on any given day, and there is not enough hours in the day for me to read all those long notes from every specialist. I need to know what you think and what the plan is and how I can help support the patient.
And is the standard note template incorporated the APSO versus the SOAP format?
Yes, the standard note is in the APSO format and has collapsible sections.
And there's a question, is the standard note a dot phrase that you can incorporate or shared?
Yeah, it's a system level dot phrase. After the update, it will become a quick action button above your notes section in every specialty. But right now, if you are outside of family medicine or general internal medicine, it's that dot standard clinic note APSO.
And then for people who dictate their notes, is there a way to take away all the dates and times that are part of the standard template for dictations?
Unfortunately, with dictation, there are rules about if you dictate, there has to be some data in there about who transcribed and when, etc. So some of that content is required in the regulatory rules surrounding transcription.
Well, there's questions. Can individual providers get access to their own note length and character count information?
Yes, we actually have that data from Epic. So the Helios team can help with that, and members of the physician informatics team can help with that. And if you don't know who else to turn to, I can help with that.
Yeah, so we can get it on an individual provider level. We can get it at a division level. We can rank you and where you fall amongst the other providers. We can rank each division where you fall within the other divisions within the Department of Medicine. So we actually have access to a lot of interesting data. And I'm going to ask my own question. What has been the barrier? You say only a third of general internal medicine has adopted the standard note template. What has been the barrier for others to adopt it, and how do you see helping that culture change?
Right. And I think that, I think no one comes to work one day and says, today I'm going to just dramatically change everything I do, right? A significant component of my work. So I think some people have specific things that they like about their current template. I think change is difficult. I think a third using the note in the first month is stunning. I think that's a really, for a change that was voluntary, where there was, no requirement, that's a dramatic number of people changing. So I was really happy with that number, and think
Yeah.
it will only grow as we continue to make things more enticing about that note, that it's just the easiest thing to do.
And then for the rollout, is it going to be rolled out beyond medicine? And what's the plan for that? And how are you going to advertise or let providers know?
Sure. So it's coming to every department in November with the update. And we're doing a bit of a physician informatics roadshow to departments and divisions together with the hopefully the physician wellbeing team or the provider wellbeing team, as well as coding and compliance and clinical documentation improvement, trying to spread the word. We may not get to every department by November, but because this isn't anything that's required, we plan to, over the next couple of months, bring the word out.
And then can you comment on, does templating itself contribute to note bloat? And what's the role of Scribes in all of this?
Yeah, so one thing, just to speak to Scribes, one thing that we're doing is over time is moving the Scribes over to the standard template, so that as we train the Scribes, we just train them on the one way to do things. So I think we'll see that going forward. And then, sorry, I forgot the first part of the question.
Do the templates themselves contribute?
Yes, do the templates contribute? Yes, the templates count towards the character count. And actually, if you talk to Dr. Kleinschmidt, he's counting how many characters are in the video visit compliance phrase, because he's a believer that his note length would be shorter if he weren't, if that phrase didn't have to be in there. But again, I think we don't want to lose sight of the real goal, which is decreased cognitive burden. The character count is just one way we have of sort of getting at what that cognitive burden might be, because the cognitive burden is difficult to measure.
Yeah. So there's a question from somebody from another department, I'm not sure which department, who conducts periodic peer reviews of notes where we are rated on clinical appropriateness, which requires background information in labs to be in the notes for context. What are your thoughts on that?
I think pulling things into the note is not necessary to prove that you thought about them. Like, especially when you think about radiology, do you need to pull an entire radiology report in, or can you say the MRI showed X, right? I think it's possible to reference those things without pulling them in when they were used as a part of your medical decision making.
Okay. Here's an interesting question from Hamid. So despite changes in CMS requirements, we are asked by our coders to include some non-clinically relevant information, such as the laterality of a metastatic site in a patient with widely metastatic kidney cancer, and told that payers will decline payment if this information is not included in the note.
Interesting. So, to some degree, ICD-10, which is what we need to code to, mandates some of the language that must be in our note. But visit diagnosis helps with that as well, because the visit diagnosis forces you to get to a specific ICD-10 code, which should be what needs to go out on the bill. I do know that there are some things, especially surrounding getting radiation treatment paid for, and some things, back to sort of the payer side of my regulatory confusion slide. Sometimes the payers, before they will go, before they will agree to pay for something, do have an extra layer of requirements.
Yeah. So a work in progress for that.
A work in progress. Yeah. Good summary.
Yeah. So there is some literature on notes as part of the developing clinical reasoning process for learners. Thoughts about closing the gap between a new documentation note and a note that really facilitates clinical reasoning processes.
Right. We actually did meet, our team met with some of the medical school curriculum team, just to mention to them that we're working on this new standard note, and we would love to help make a version of this note for learners. incorporating some of the same principles, but maybe having more help texts or things like that to help the learner learn to write a good note, but yet using tools.
Yeah, I think that would be great as well. So then this is more of an implementation, or is there a tool in HealthLink to help with time-based documentation?
Coming soon.
Okay.
We're looking at a functionality of that Epic has where Epic will time how long you spent in the chart on the day of the encounter to help you with the time, to calculate the time. There's some caveats to how it measures, etc., but we're working on that.
And then a comment from Pete, I'm assuming this is Pete Kleinschmidt. Shorter is better, but the real issue is how effective in patient outcomes, in effectiveness in handoff events, and in creating a process that helps the provider think through the data.
And I think helps others to quickly see what your thought process was, as others are, in a cross coverage situation or an admission situation.
Okay. And then some people put in, there's a bunch in the chat, so I'm going to try to, maybe that's P Newcomer. Okay. try to go through some of the chats.
Hey, Lynn, could I ask a question here?
Yes, please.
So Heidi, I just have a question. We work with phase 1 and phase 2 learners in the clinic setting, and they're really at this beginning phase. What is the curriculum right now in the medical school in this area? And should we really move to this standard template, which is what I'm having the phase 1 student who works with me do?
Yeah, I would love to help coordinate between our team and the medical school curriculum development team to see if we can figure out a process for those students.
Some of those people are on the line right now, so.
Yep.
Mhm.
And do you see this note or change in note templates being rolled out to other healthcare providers, other members of the healthcare team, nursing notes, PT, OT, etc.? There's also a lot of note bloat in those notes as well.
Agree. I think we're at the beginning of our anti-note bloat work, but again, they have, especially in the therapies, they have their whole own set of regulatory things that they're accomplishing in those notes. So I think it will take a new deep dive into those regulations before we can think about chipping away at those.
And with the advent of open notes, has there been any further information of what patients' reactions to notes? Do they like shorter notes versus longer notes? How long it takes them to read notes, etc.?
Right. I think we're just starting to study the patient use of notes. I think a few years ago, I came from an organization that started sharing all notes 4 years ago, but we had very low readership rates, less than, single digits in primary care, up to maybe 20% in the specialties like genetics and oncology. But I think really this last year with open notes and much more public facing advertising of you should be able to read your own note now, because everywhere in the US you can read your own note. I think that will really increase readership. And now the time is right for learning more about what the patients need when they're reading the note.
And we focus a lot on the time spent by the provider writing the note, which we can quantify and measure. Do we know anything about the impact of these changes on the providers reading other notes, the reading time?
Unfortunately, the time documentation that we have for reading of notes is just all called in the way that Epic measures time spent in the EHR is just part of chart review. So it sort of gets mixed in with, reviewing labs and everything else in the chart. So we don't have a great way of looking at that individually. Epic also has data that as physicians spend less time writing notes, they tend to spend more time in, if their total number of hours in a day doesn't change and they spend less time writing notes, what absorbs that is more time in chart review, which might be a good thing if you feel you have more time to explore the chart effectively at a visit. But
Okay, I think I've hit most of the questions. There is a call out for others besides primary care providers to update some of the list as appropriate. Okay. And so what's the plan for rolling it out? How are you going to be, how are you going to be communicating across the different subspecialties and following up on it? And
so expect physician informaticists together with coding and compliance representatives coming to various department meetings or division meetings over the next few months to talk about this. You can expect that button will appear in every department with the update in November to make it easy to get to this new note.
great. All right. Well, I think we're all very excited. And Betsy, anything else you wanted to mention?
No, I just think that Heidi coming to join us has been a breath of fresh air. And I just also want to give a shout out to how few women there are in high level leadership roles in informatics. We've happened to have had our first chief medical informatics officer as one, and Heidi. So great job.
Thank
Yeah.
you.
Heidi's been a great asset, just being able to see the data and demonstrating, where the opportunities for us as a department and as division to improve efficiencies and time in our electronic medical records. I really do think that's going to, with changes to move forward, that will improve professional fulfillment and ideally decreasing burnout and being able to spend more time doing quality work with our patients and not focusing on regulatory documentation and bringing in stuff that no one reads about but takes up a huge amount of our time and effort. So emphasize from Betsy, Heidi is an amazing resource. We're very excited to have you join, to have you as part of the department.
And I would say I'm hideous with the electronic medical record, my efficiency, and I have moved to the AppSoNote. And while I am still relatively clunky, it has been fantastic for me. And I've talked to several other people in GIM who have had excessively long notes, and it has been really a game changer. So it's worth trying.
Okay, great. All right. Well, thank you all. Thank you, Heidi. Thank you, Betsy, and have a great weekend.
Thanks for the opportunity to present. Bye.
Bye.